Morning. Good. What we got here? Maya, Ivana, Katoki, Christina, Marshall. All right, this is reasonable to go forward. Okay, so I apologize in advance. A somewhat shortened version of EP conference this week. Busy this weekend. Here's the first tracing today. So this is patient who has a dual chamber implantable pacemaker, and this was a tracing on tele that was recorded while the patient was having a pacemaker check. So my question to you is, what do you believe that the interrogator was testing here? And what are you seeing happen here? So why don't we go to Dr. Maya Kalis of the Midwest, Wisconsin.
All right, morning, Dr. Pass. So it looks like initially the pacemaker is asensing and V-pacing,
Yep.
and then it switches to just V-pacing and not asensing. So I think they are testing the atrial sensitivity.
Okay, well, can you test atrial sensitivity when the patient is asens V-pacing?
I guess not. You'd have to be A-pacing.
Well, no, sensitivity is, what is what are we testing when we test sensitivity? The wire is sitting in the atrium, and I say, I want to know what the sensitivity of that is. So what is that testing?
I guess it's testing, like
It's in
if
the
the
word sensitivity.
pacemaker can, yeah, like if the pacemaker can sense the signal that is being generated.
Right. So remember always there's two major functions pacemakers do, right? One is that they pace, hence the name pacemaker. And the second is that they sense, right? If the patient has their own intrinsic rhythm, a pacemaker has got to sit back and not do anything. So you need to be able to sense in order, and particularly in a dual chamber pacemaker and somebody who has normal sinus node function, it's very important that the atrial lead can sense well, because chances are in somebody who has isolated complete heart block but otherwise has normal sinus node function, it will likely be asens V pacing almost exclusively. So, when you look at the counter, it'll be like 99% asens, 100% V paced. So can you test the sensing of the atrium when a person is in asens V pace rhythm?
I guess you could.
Right, because the patient, as long as you're sensing, as long as you're in a modality where there is an ability to sense the chamber, you can sense, you can check it. So although I agree, and I assume the reason you're saying that we would be checking sensitivity during this tracing is because you see the P waves that are not conducting.
Yeah.
And they're more obvious maybe than in the asens V-paced beats on the left-hand side of this tracing. But in actuality, the pacemaker should be able to very easily sense these beats, the atrial beats on the left-hand panel. So I would posit that this was not what in this case, I believe it was the Medtronic rep, at Sinai, the Medtronic reps will come by the next day and test everybody, which is a nice service that somebody arranged it, but long before my arrival here. So I don't think they're checking the atrial sensitivity there. Anything else they could be trying to test? Why would they? What is the ventricular rate on the right-hand side?
Let's see. It's 300, 100. I guess it's somewhere around like 30 or 40.
right? So, what else do you think they could be testing or trying to test here? So the most important things we do at the bedside when we're testing is testing sensitivity. By the way, just for the record, the atrial electrogram in this particular patient was actually 6 millivolts, which is very, very large for an atrial electrogram. So this was actually an excellent implant with very fine sensing in the atrium, just for the record. Um, but what do you think
So,
they were checking on the right-hand side? We just lost Maya.
sorry, my internet cut out and
Oh, sorry, you're
I'm
back.
sorry, what question?
I was saying, what do you think what are we checking on? Why did the pacemaker rep allow the heart rate to go down to this very slow rate?
Maybe we're checking the backup rate, um, like the like I'm guessing there's some sort of DVI backup, in case, something happens with the A wire or, something else is going on. So maybe he's checking
Well,
the backup.
what I don't know honestly, because I wasn't there when this test was done, but I'm going to guess that what the pacemaker rep was doing here was actually trying to check ventricular sensing. Okay. So how would you, let's say you had a patient who had complete heart block, had an escape rate of 50, right? We've had many patients over the years who've had postoperative heart block, but they have a reasonable escape rate, right? We have a patient upstairs right now who goes 2 to 1 occasionally, but even in 2 to 1 has a reasonable escape rate. But when you have, if you have an escape rate of 50, how would you check the sensitivity? How would you test how large the electrogram on the ventricular lead is if you wanted to in somebody who has a complete heart block but has an escape rate of 50?
So you want to check to see if the pacemaker is sensing that appropriately.
That's right. That's right. So how would you do that? How would you temporarily program the pacemaker in order
So I
to
would
check?
temporarily program it to VVI backup rate of less than 50. Like I'd
That's
set it
ex
to like
that's
40 or 30.
exactly right. That's exactly right. You would set it at like 30 or 40 and watch the pacemaker's ability to sense the intrinsic activity. Why does it matter if it can sense? If somebody is A-sense V-paced 99.9% of the time, why do you think it matters? Why don't we ask Christina? Christina, why does it matter if the ventricular lead can sense at all?
I think it matters for a sense because for AV synchrony.
Well, but if you're not conducting virtually ever, and if the
Hmm.
atrial rate is always what it normally is, let's say it's in a small child, it's 100, then you know that your atrial rate is always going to be greater than 100. So you will always pace the ventricle at above 100. And so in theory, if you have like complete heart block and your underlying rhythm is heart block at 50, you would never really lose AV synchrony without sensing. So why is sensing matter at all in a patient with a permanent pacemaker, you think?
Um, so maybe to prevent triggering a type of ventricular arrhythmia.
That's exactly
Um,
right. That's exactly right. So you don't want it to pace, even if you're A-sense V-paced, you could occasionally have a PVC. You want to make sure that it's sensing all ventricular activity so that it appropriately waits the correct interval after a sensed event, any ventricular event, before it paces again. What you don't want is to pace on a T wave of an undersensed QRS complex. and have a problem potentially. So granted, that's a very rare occurrence, but it is not impossible to imagine, and in fact could happen with some regularity that the person's going to occasionally have a PVC. So you definitely need to be able to check the sensitivity. And so what's happening here is that the pacemaker rep has lowered the heart rate. This is a rate, right? This is cycle length 1488, which corresponds to a heart rate of 40. So the rep has lowered the heart rate to 40 in the hopes of demonstrating intrinsic rhythm in order that he or she could provide for us what the R wave is. In other words, how good is the sensing on this lead? And it turns out that at 40, the patient is still paced 100% of the time, which means that the escape rate is below 40. And so presumably in a baby or a young person, the representative was not feeling comfortable to go below this rate. And you will see that when we do pacemaker checks, if you ever see any of my notes in the office or Barry's notes about checking thresholds, if the escape rate is very low, we cannot test the sensing on the ventricular lead. So that's just, the fact. And so sometimes that makes us a little nervous because we don't actually know what the R wave is. But we assume that if the pacing impedance is normal, if the pacing threshold is normal, that probably the R wave is large enough that it would be sensed in the event of an intrinsic ventricular event, and it would not pace at that time. But it's an interesting example. And unfortunately, although we knew that this test was done, we didn't know exactly what time. And the fellow who was on call was nervous appropriately because it appeared as if this was a pacemaker malfunction of some sort. But in fact, this was just the doctor, I'm sorry, the Medtronic rep doing a test. And that brings up another point, which is whenever we're doing tests of pacemakers of patients in the ICU, it's critically important to let the nurse know in advance that you're about to do this, because you will routinely do things like this in order to test the device. And so you don't want the nurse to start running, to run into the room thinking something is wrong with the patient because you see such a slow heart rate as this. I actually tested this particular patient's pacemaker after arrival from the ICU, and I also was unable to check the R wave in this patient. If you look at my note on the patient, which we can go over at another time, I do not actually comment on the R wave because the intrinsic rate was too low. Patient's heart block was pretty deep. Now, it's possible that if you slowly walk the patient down, if she had gone to 30, which is the lowest rate that the device will allow her to be in a sensing mode, that the patient might have had an intrinsic rate, and it might even start to rise up. There can be some suppression of the underlying escape rate when you are paced chronically, but it usually will come back in a few seconds. But the last thing you really want to do in somebody who just had a pacemaker, particularly if it's a big surgery, is to make them faint in bed because you have a heart rate of 12. Doesn't look very good, not so good for the patient. So generally speaking, we would just do this. I would usually, if I was doing this test, allow 3 to 5 beats, and then if it wasn't sensing, just go right back to pacing on the assumption that the underlying rate is just too slow to test. Any questions about this? Okay. Oops, sorry. Mistake. All right. This tracing was sent to me by a fellow at some time in the past, and this was a patient who had an orthotopic heart transplant, and the patient was not being paced, however. But this was observed on the telemetry, and so my question to you is, well, what is going on here? How do you explain this? And why don't we ask Doctor, since it's a transplant patient and since we have a potential transplant doctor here, let's ask our guest, Dr. Molly Marshall, what she thinks about this.
Good morning. So we know for a fact the kid's not being paced, you said, right? Like not
Yes,
connected.
we know for certain that the pacemaker not only is not pacing the patient, but is not even attached to the pacing wires.
Uh-huh. So whenever I'm seeing anything that doesn't make sense to me like that, that's my first thing I would check. And so we know that that's not happening. I don't fully know exactly why, but I know that sometimes I'll see this on telly, and I don't know if it's just a fault, I guess, in like the settings, because this is like a setting of the telemetry that it tries to pick up what they attribute to be a pacing spike, which sometimes can be helpful when you're checking with a patient pacing, but you have to be careful because it may not always be accurately reflecting if there's actual paced beats, which like it sounds like in this kid, we know that there's not. It is a lot though. I don't know that I've ever seen it like that many times, but there have been times where I've seen like a pacing spike show up on like tele review and we know that the patient was not being paced. So it's picking up something, but I'm not sure what.
Right. That's exactly right, Molly. So this is, I'm showing this tracing because I think it illustrates to me what is bad about the so-called pacemaker modality on monitors. So our monitors allow us to have this pacemaker modality, which is looking for high frequency signals, and then it will augment it. Typically, the frequency that it's looking for is only seen in, or almost always seen only with pacemakers. And so it augments the signal, makes a spike on the electrocardiogram on the monitor. And in theory, it's supposed to make it easier for the bedside personnel to know, what's being paced and what's not. The reason I have always been a big critic of that modality because of exactly this type of tracing here, which is, well, there's a couple of reasons I don't like it, but this is one of them. And this is just essentially some form of artifact that the device is detecting and is augmenting. And it doesn't even, it doesn't really, it seems like it must be some kind of a mechanical device because it's happening with a very strict 3 beats in a row, 3 beats in a row, 3 beats in a row. So something must be vibrating on the patient or something, some sort of device. Let's see, or someone's asking a chest percussor. Could be. It could be a chest percussor, but something is being done to the patient's chest, and that's as good as any other possibility. So good call there, Ivana. But the device is basically sensing this electrical activity and is augmenting it. And the other reason that I don't like this modality is because people confuse the presence of a spike. Let's say it's working properly, that it is actually only detecting pacemaker spikes. The reason I don't like it is because people confuse or conflate the presence of the pacemaker spike with capture, which are not, of course, the same thing, right? If you're pacing at too low of an output, you'll have a pacing spike, but you won't actually have capture. And I have seen that error made where the bedside personnel thought that the patient was being paced, but they were not. They were being paced, but they weren't capturing. And so the patient's heart rate was very low and much lower than the paced rate. So I kind of have never really been a big fan of it. I used to have long conversations with Dr. Ofori about this. But he unfortunately liked it, and he passed his like of this to Dr. Iden. And so I now complain to Dr. Iden all the time, but as you can see, it has had no effect at all. And so we still are bothered by these types of tracings occasionally. And the fellow who saw this tracing, who's Dr. Mukhopadhyay, was justifiably concerned and was kind enough to wake me up on a Saturday at about 6:45 to ask what this was. So we figured that out together. Okay, let's go to our last one. This is an electrocardiogram that was shown to me some point in the past. And my question to you is, what is the diagnosis and how would you evaluate this patient? Let me ask Dr. Kitoki Mukhopadhyay, visiting us from Eastern India. Toki, you still there?
Yeah, she's
Sorry.
just getting her audio up.
Sorry.
Good morning, Dr. Pass. I'm looking at the tracing at B1. A P wave is followed by a QRS and then a T wave. So I've got 2 sinus beats, and then we've got 2 beats in a row after that, where the QRS morphology has changed, as well as the PR interval has changed with respect to the Q wave. And I also see a delta wave. So I guess this is intermittent pre-excitation, because it goes back to the previous rhythm and then it happens again.
That's exactly right. So this is an example, very good, Kentucky. This is an example of a patient who has intermittent pre-excitation. And what's unusual is you don't actually normally see this on just a 12-lead ECG, which, as we know, is just a recording of 12 seconds. So it's pretty cool that we could see this all just on one tracing. And I'll remind you, we talked about this like 2 or 3 weeks ago. If you look at the so-called Oklahoma map or the Aruda map, the R wave being so tall, so much taller than the S wave in V1, this would be very suggestive of a left-sided or left lateral accessory pathway. And just to remind, if this patient were asymptomatic, Katoki, do you recall what we're officially supposed to do in this circumstance? According to the American Heart Association and the Heart Rhythm Society and the ACC, from that 2012 statement that we reviewed briefly a few weeks ago? Is this, so let's say this patient, had this electrocardiogram. Let's pretend they were having, that they have ADHD, and somebody thought that they needed to have an electrocardiogram, because as a screening test. And we can talk about whether I believe that's necessary. But aside from that, this is the EKG that was found. This patient tells you they're completely asymptomatic.
I would monitor this patient and probably get a ZO and see how their rhythm looks, or maybe stress test them.
Well, yeah, I mean, according to the, I think maybe I'm getting your back feed there a little bit. According to the official recommendations, you'll recall that intermittent pre-excitation, if you had an asymptomatic patient with intermittent pre-excitation, you don't actually need to do anything further according to those recommendations. They suggest that you are at low risk for sudden cardiac arrest, and in the absence of symptoms, you don't have to do anything. Now, that is the formal recommendation, but as we discussed a few weeks ago, there are examples of people who have intermittent pre-excitation and absolutely have high-risk pathways. So although it is almost certainly true that in general, on average, if you have intermittent pre-excitation, your risk of sudden cardiac arrest is probably lower than the average person who is not pre-excited, who is lower than the person who's pre-excited all the time. We can't really hang our hat on this. So probably doing a stress test would not be a bad idea. However, it's important to note that a lot of electrophysiologists in 2024 would say that this patient, despite the fact that they have intermittent pre-excitation, should undergo formal electrophysiological testing in order to determine if they actually are at risk for sudden cardiac arrest. Remember that we talked about the fact that particularly when the pathway is left-sided, because the accessory pathway is so much physically farther from the sinus node than the AV node, one can be intermittently pre-excited without actually having a low-risk pathway. In other words, the AV node may be very robust, as it is in young people, and you could conduct through both, but that doesn't necessarily mean that your pathway can't conduct rapidly in the setting of a rapid arrhythmia, such as atrial fibrillation. So for me personally, with this type of a pattern for intermittent pre-excitation, I probably would recommend a formal EP study in order to determine if this was a higher or low risk pathway. The other scary thing is that there have even been studies showing that people who pass their testing in the cath lab can rarely go on to have sudden cardiac arrest as well. So now there's a slow move to consider even ablating everybody with WPW. I personally am not quite there yet, but because I do think that that implies that there's zero risk to ablation, which I think we all know is false. But it certainly isn't an unreasonable viewpoint. There are definitely cases in the literature of people who have not only had intermittent preexcitation, but went on to have an EP study, passed their EP testing, showing that they don't conduct at rates above 200 beats per minute with formalized testing, and then went on to have a cardiac arrest from rapidly conducted atrial fibrillation. So we can't really necessarily hang our hat on this observation. But according to the formal 2012, and that is the most recent statement on this statement on people on WPW, if you have intermittent ventricular preexcitation, you can, at least in theory, just tell the patient to call me if I have palpitations or fainting or any other cardiovascular symptoms. Any questions regarding this? Okay. I think I'm going to stop here. Sorry for the slight abbreviation today. Thanks for joining, and see you in Sinai in just a little while, guys. Have a good day. Be well.
Thank you.